Do you have a point? Yes. Okay. And it moves from here or just from here? Slide movement?
This is
From here?
Yes.
Okay.
If you want, I can bring mine.
No.
So you can move from there.
No, I'm just checking this one, right? All right. So, as Dr. White told me, you are not used to salary and efficiency, right? So, inshallah, we will just do the down to the link. And I will leave the lecture here so that you can later check with him. So, little bit about where I am. I mean, I'm sure all of you know where Florida is. So, I'm right there. This is called North Central Florida. And I'm in a city called Gainesville. Okay? That's where the University of Florida is. So this is the university. The whole university is in this area. And there are near 70 buildings, 170 buildings in the area, which make the university. We have about 55,000 students in the university and 70,000 faculty total in this area. So the whole city is university campus. Everything runs because of the university. And this big building here is the School of Islam. We call it business right here. This is the Health Science Center, Medical School. This is the Brain Institute. For research, there is one new building coming which is called Nanotechnology and Research. It's coming up. So this is the whole campus of the university. Another view. That's the College of Dentistry right here. And I work in this floor right here. That is the entrance. These are some of our students. There is something called white coat ceremony where they put the white coat and show you that the same experience. Just to start the lecture, in oral pathology, this is something all of you must know, that we have to be very alert in oral pathology. And most of you want to be specialists later. Now you are doing general dentistry. But for me, the difference between a clinician and a technician is only one, and that is knowledge. If you become dentist, but you don't remember your knowledge, then you are no different than a technician. If you remember your knowledge, then you are a clinician, because you can identify the problem. And when you are identifying the problems, you have to be always alert. Because you may be looking other place, but what you are looking for is sitting right in your head. This hunter is looking for the deer, but it is looking another time. So we have to be careful about that in life, in general. So this is just a small slide review. All the cases here are what we receive as case concerns or patients from the floor. We do a lot of consultation in the clinic floor. But I'm sure we're doing the patients come, the floor, the companies to go. We take pictures of residents who train on us, carrying the camera. When we get problems, we take pictures, go to the folder. Immediately, everything is categorized. So we will catalog everything. And all of this is the product of that. So you said no sanitary, right? There is no. Okay. Odontogenic is open, right? You did odontogenic? Odontogenic, yes. Okay, good. So let's do odontogenic, and it's again something we've all done. This is a 48-year-old male with a radiolucency involving number 17. Now that may be a confusing number for you, or I don't know what system you are following for my description. So America is weird. It has everything is different in America. Okay? So if you call something brinjal, they call it eggplant. Similarly, number 17, they start numbering from here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, and then 17. So lower, first molar, third molar from here. Number 17, radiolucency. But I don't know, when I was in India, we used to call that 38. What do you call it? 38. So that's how we were in India. So 1, 2, 3, 4.
If you put the hashtag,
Right.
doesn't mean it's digital.
It's called number in 17. Number 17. So obviously you can see that nice, well corticated radiolucency around the crown, and I'm sure you have a diagnosis. Integer assist, mashallah, that's the right answer. There is always a second name called follicular cyst, which means the same thing, and it is composed of nothing but multiple layers of flattened stratified squamous epithelium. This is the connective tissue wall. That's a very simple diagnosis. There is no confusion about it, and it can be sometimes very large in size, and I'm sure you have read about these. The most important thing is to form because the follicle around the crown starts to separate. And once fluid starts to collect, it will grow its size. That's the reason. And I know that all of you know a cyst is nothing but a pathological cavity which is lined by epithelium. So what happens is inside the cavity in the lumen, the keratin debris starts to collect, so the osmotic pressure goes up. The fluid will start to come in to maintain the balance, it will become large. Again, some debris will collect. And this is the dynamic process. That's how the cyst will keep growing in size. This is a 35-year-old male patient. So we say 35-year-old male. Okay? Radiolucency of the right angle of the mandible. Oh, this picture probably got changed. But this is another radiolucency which is involving only the apices of this maxillary molar. And there is definitely some carious lesion. So the most obvious choice will be something like an inflammatory cyst of apical or periapical cyst. Exactly. But this turned out to be a slightly different entity, and I'm sure you will reach the answer. So when we look under the microscope, this was the line. So it looks like a cyst because this is the blue berry. And you see this about 4-5 cell thick. But the basal cells look very, we call it hyperchromatic, very deep blue. And if you see carefully, here, it looks like the nuclei are pulling away from the base. See, they're moving away. This is called reverse polarity. If you heard this word, reverse polarity or peripheral macrolization, is a classic sign of ameloblastoma. So this is a type of ameloblastoma called cystic ameloblastoma. So sometimes we can be confused because the presence of here, like periapical cyst. So that, the endodontist basically biopsied that, sent to us. But luckily, because he was smart, we found this line. So it was actually a cystic ameloblastoma. But cystic ameloblastoma again has better, prognosis because it behaves like a cyst. You can just remove that one, immediate, and that will take care of the disease.
So we can go very slowly.
No, it is very, yes, we can, provided you have the entire specimen. If there is incisional biopsy, we will never say cystic ameloblastoma. Then we will say ameloblastoma, C comment. And in the comment we will say this histology is purely cystic, but microscopic examination of the total specimen is important. So we will make a comment. That means we submit the whole thing, then we will make the final answer. But if the patient is saying we submitted excisional specimen, then we will say this is a predominantly cystic lesion, so you can be, little more careful and just be very, very casual about it, not aggressive treatment. So these are the few facts which are all basically in the textbook, so will not really go, and it is only 10 to 20% recurrence, which is comfortable compared to the usual recurrence of amyloblastoma. This is a 23-year-old female, number 32, which is actually 32 means for you 48, okay? And clearly you can see this massive, which is literally involving the entire mandible. Well, I mean, if you see this, the first differential has to be amyloblastoma or something like a weird osteosarcoma. So you see the CT completely exploding the entire jaw, almost from the angle to the angle. And then starts to break the cortical bone right there. What is this feature called? Martin. That is the best word to start. Nowadays we don't see a word in the book which I'm sure Dr. White saw and we saw when we were studying. I'm sure you followed Schaefer's book, the following it sometime. It was called egg shell crackling sound. So when you touch it, like this one, if you press, you actually hear the sound, like you're breaking egg shell, We used to have that in our textbook when we studied, but now they remove it, they don't use that word anymore. In the level, but in the level book, they're not even using it. Which is strange, because maybe they're thinking they are so good, they don't reach that stage anymore. But we still get patients which have such a big swelling. Or the other name is also honeycomb aneurysm. Another one. So there are multiple differentials for a lesion like that, not just a amyloblastoma. Can you name one that crosses the midline? Any other lesion? Not necessarily a problem, but anything else? Yeah. The magic bone is automatic bone cavity can be that position. There is a aneurysmal bone can also be there. But there are two more interesting APDs. Keratosis can be anywhere, yes, it can cross the midline, but generally, more commonly in the posterior segment. Adenomatoid, but mostly in the maxilla. Okay? There is one entity called central giant adenoma, sometimes will cross the midline. Yeah, that's okay. And another one, glandular pathologic cyst, can tend to cross the midline. Okay? But that's fine. I mean, you will learn about central giant adenoma when the time comes. So sometimes the oral surgeons will make this nice marking about the lesion and put the mark of the nerve, then just to give us an idea how they got it and how much involvement was there. Another lesion going almost up to the coronoid process. Another one in the maxilla. Now the maxillary lesions are always much more aggressive because the maxilla has cancellous bone, so it tends to spread too much. The treatment changes drastically when the lesion is in the maxilla. And this is what you see under the microscope. It looks just like an enamel organ. If you remember the histology of the embryology class. And these are called, this is the same thing, the effect which I was telling you, look at those small vacuoles, that is called reverse polarity. And that is a hallmark for the diagnosis of amyloblastoma. There are many features, but I'm just putting this small slide just so that you know if you see something like this ever, this is an amyloblastoma. There's no other diagnosis for this entity. And this is a maxillectomy specimen of amyloblastoma. I mean, clearly it's completely destroyed the maxilla. I mean, the most important take home from this, I think, is what we see here. Most of the types which we see are the conventional type or the solid type, the reason for that exploding lesion. Whereas the unicystic is the one I showed you before. Peripheral is not so uncommon. We do get some rare examples, but again the recurrence rate is much lesser for peripheral lesions. This is a 58-year-old lesion of the left maxilla. Female. Yes.
It's common in men than.
Yeah, only thing is this was a slightly different case, and AOT, I would say classically, is in younger female. It isn't female, no doubt, but always remember if you have a younger history with something where the clinician is saying, oh, I see this mixed radiolucency and I see an intact tooth, then we think about AOT history, okay? But in this case, it was little different, a very rare entity. If you look at the literature, you hardly find examples. This is the case of immunoblastoma. In fact, it is so rare that when you see calcification in immunoblastoma, you actually almost don't call it immunoblastoma because we know by definition immunoblastoma should not have a product. This should not be a calcification at all. But this entity almost behaves like an immunoblastoma, but we also see dentine-like material in the lesion. So this one, we have not reported it. If you search literature, maybe 3 or 5 cases in the world. And we have one case with us.
Just like immunoblastoma with institution. Just like immunoblastoma with institution.
With dentinoid product. Like we see dentine in the tooth, we see product that looks like dentine within the lining stage. So then we end up calling it dentine, and we go back on dentine. You see, I told you, the pathology is one of the easiest subjects. Let's mix up the 2 words and we get a diagnosis. Right? 41-year-old female, number 28, 29 area, mixed, radiolucent and radio-opaque lesion. So pretty middle-aged female, and you hardly see anything, but if you make out a slight radiolucency and kind of a fuzzy radio opacity there, but almost looks like normal, with little or no change. This was another one, almost taking some root divergence. Another one right here, you can see some radio opacity. All the same entity. Histologically, we saw this. And we call this both cells. So what is the diagnosis?
Calcifying.
Calcifying is down to the cyst. What is the other name? Jordan cyst. Pretty much is calcifying epithelial layer. There is a lot of confusion, but you guys are doing good. I'm proud of you. You are doing better than our students, let me tell you. So that means your study. Oral pathology is all about study.
Actually, better in the lecture, but in the exam.
You know, life is not an exam. If they retain, and if they see, what is the ultimate aim? That great sheet is not that great. I think the ultimate aim is the exam of life. If you look at the diagnosis and look at the radiograph in the real life, the job is done. Because you and your patient are the main relationship. But in life to come up, you also need the great sheet. Because nobody could accept you without a good grade for training for master. I told you, even for English, now we have 2 students, they are stuck because they have TOEFL score, which is less than 80. If they don't get 80, they cannot get into the admission. So even English is so important. So marks are important, but knowledge, of course, is the final product. So we call these, those cells, which is nothing but probably coagulated or necrosed keratin. More of the same. And you're right, this is the golden cyst. That was a wonderful diagnosis. And then again, these may be seen along with odontomas or AOTs or in combination with ameloblastoma. 8-year-old female, radiolucent lesion inferior to S and T, and these are for deciduous teeth. So they again start ABCD, FGHIJ, KLMNOP, something like that. So you can understand Americans are always different. The only thing, thankfully, is common. Because we all drive on the right side of the road. I don't know, I think they didn't find any other side of the road. Otherwise they would have made cars which would have nothing.
British made it right now.
But British is like India, so we have left side.
Yes.
So this was the lesion right here, kind of expanding the jaw a little bit, especially buccally. Some radiolucency there. It's not a very good radiograph, this one. But here, empirically, you appreciate that definitely swelling there. And then again, it involves the crown of this impacted tooth. Any ideas? So this was the histologic results. I mean, you can argue with me and say, this looks just like a neuroblastoma or systemic reticular. But if you remember, when we showed the picture of a neuroblastoma, the stroma on, this was not cellular at all. You know what this looks like? It's like a dental papilla. If you remember the dental papilla, that's how it looks. So if you see dental papilla like stroma with these small islets and strands of parts of the abdomen, this is called adenoblastic fibroma. Okay? And the most important clue for the diagnosis is actually here. Look at the age. It's classic in younger people. Okay? Just, so that you know. So this was a nice case of adenoblastic fibroma. It's a mixed tumor and it has a conservative excision will generally take care of it. Next case is a 13-year-old female, radiolucent, radiopaque lesion of the posterior mandible. So you can see definitely a mixed radiopaque, radiolucent lesion, and then some more of your tooth-like areas. Another one there. What do you think this is? This picture is not my microscopic, this is from the head, but it shows a decent crystallography. Actually, if you look at this, no different from the adenoblastic fibroma, right? And then what is this? Just a developing tooth, almost odontoma. So this is called adenoblastic fibrodontoma. No different from the adenoblastic fibroma, except now that there is a tooth. Many people actually believe that adenoblastic fibroma, adenoblastic fibrodontoma, and odontoma are continuous. It's just a different stage. Yes, and it can actually destroy both. It can. And some believe it is a continuum to the product odontoma. And it can sometimes also cause prevention of tooth eruption, just like the odontoma. 60-year-old male patient, peak 27, 28 radiolucency. You can clearly see the lesion there, probably causing extrusion of that tooth and both buccal and lingual cortical expansion, and that is the radiolucency. Any thoughts? Other? Well, actually, that's a very good thought. I'll give you a small clue how we approach it. Whenever we see anything like that, age, I'm not saying always, but older age, think about slightly bad things. And this is not that old, but generally if you see 65, 70, 80, bad things happen when people get old. Okay? Because nature created us to get destroyed. But now because of modern life and all kinds of things, we are living longer lives. But then our body is burning. So my logic is, when you see an older patient, think about bad things. So your degree of suspicion should go up when you're evaluating older people. And in this case, and you're right about your depression, so one of the best depressions will be osteomyelitis. But osteomyelitis will not cause tooth exclusion like that. So you should start with something malignant than to the nerve, the first differential. And that kind of fuzzy, look at the borders. It's really very, very, wacky or moth-eaten like. So this was a case of, look at that, how it is causing a pathologic fracture. Malignant tumor. Absolutely. You have to put malignant in the top differential for you. And this was the histology. So it looks almost like some peripheral palisading, which is almost like an immunoblastoma. But now we see this keratin formation. We can see very atypical cells. So it is actually amyloblastic carcinoma. There is a very important thing to understand, and it's very confusing sometimes, especially in second year. We say amyloblastic carcinoma, then we also say malignant amyloblastic carcinoma. Now this one is an amyloblastic carcinoma because you see the carcinoma in the amyloblastoma. But if I see an amyloblastoma in the lungs, that is malignant amyloblastoma because it is travel resistant. From a regular amyloblastoma?
Just for amyloblastoma, from patient to other
malignant, exactly. Because the definition of malignant is metastasis, so it is moved. Whereas this one is primary tumor, but you see cancer in the tumor. So, not amyloblastic carcinoma. And this was a very interesting case of amyloblastic carcinoma. So, all these lesions you see, I sign out every day, 50 cases, at least every day. So, we will have 2 squamous cell carcinoma, 1 salivary abscess, 2 pleomorphic adenoma, 1 adenoid cystic carcinoma, 1 endomorphic. This is routine. Every day you will have out of 50 cases at least 5 to 7 entities. Maybe a lymphoma, high grade cell, extreme bar. We just had a bucket. So when I took the flight on Friday, Thursday, I signed up a bucket lymphoma in a 6-year-old female. Okay, one. And the other one is an osteosarcoma, chondroblastic, in a 17-year-old girl. So I don't know, I started the patient and I tell my boss, today is all child case. Bad day for children. 2 cancers, both young kids, 6-year-olds and 2. So this is day to day. So life becomes very interesting, because these are not easy cases. You see, you know it's a lymphoma, but you can't spot it. You have to run the stains and you have to do rush, you have to do flow cytometry, gene mutation transfer, all of them. So it is like, it's roller coaster, roller coaster? Yes. It's like a roller coaster. But it is also interesting because you feel you are doing good, some good, to community. You feel good. That's the only reward, As a teacher in America, I don't make too much money, okay? But I feel good, I can tell you that. Because that proves that money doesn't make you happy. It can give you something, but not full happiness. But when you give some impact to society, that makes you more. And that, I think we have enough of that. 37-year-old female, and all of this will not make sense to you now because you're very young. When I was like you, for me money was very important. In 10 years, I knew money was not at all important. That's when I changed my life. 37-year-old female, radiolucency of the left mandible. And this is on the left side, but generally these lesions will be seen in the central area of the mandible. We call this microcystic spaces, and these are bud-like proliferation. It is an odontogenic line, okay? This is a regressive lesion actually, can cause significant destruction of the bone. This is in between the teeth, you can see some root divergence. The other name is cyano-odontogenic cyst or glandular odontogenic cyst. So this is a recurrence rate very similar to the OKC, okay, or odontogenic keratocyst. 56-year-old female, radiolucency of the left mandible. And you can see a very small radiolucent area right there. What would be a top differential? No, this is between lateral periodontal cyst would be your differential, definitely in that location. And this is another case which is very multilocular. You can see it is involving a large area. Another one which is almost like a lateral periodontal cyst. This almost looks like, although the tooth is not involved, it looks like something which is inflammatory. This is the big one. These are all the same entities, okay, in different patients. Multilocular. There's even an impacted canine tooth. So now you must be getting some idea that this is not the usual you see. I mean, if this was my case and this radiograph was sent by an oral surgeon saying I have this patient who is swelling, what do you think? My trust would be unlimited, like without even a doubt. Number two, OKC. That's how I would go. Right there, involving the crown. And then, you get some more clues. You start to see this multilocularity, trabeculae of bone there, on the septa. One more on the left, on the right, sorry, on the right there. The same lesion. Some more here. These are all different presence. Now this one was very confusing because the endodontist thought this is a periapical lesion and there was some questionable vitality test. I mean, all of these things keep happening in the neck also. So, people start to go multiple endodontist treatment, nothing gets done. Then finally somebody wakes up and does a radio biopsy, and this was the histologic presence. So, what do you think this is called? The basal layer. What is this pattern called? It's called peripheral panicate or picket fence arrangement. Okay? And we see this corrugated parakeratin on the top. This is the classic OKC. What is the new name? Absolutely. That is the most acceptable name, but there's still a lot of old providers who will call us. If we say keratocyst tumor, then we get a phone call. So what is this? Because these are old surgeons. So what we are doing now, keratocyst tumor, then we put parenthesis, tumor. So no more phone calls. Because there's no time for phone calls, So what would you suspect if there's a young child, 11-year-old, with multiple odontic symptoms? What would you evaluate the patient for? What kind of? So the patient already diagnosed. So the patient has 2, 3 pounds radiolucency all over the mandible, and we've done biopsy, and you have diagnosis. All of those are OKCs. Child is 11-year-old.
Interval syndrome.
Exactly. So that's where you change your spectrum of thought. You bring it. Okay, there must be a reason. This is a very young patient. Let me say now, this patient is 23 and also has a basal cell carcinoma. The skin lesions. So I'm sure you remember, it's not falling in place. It's called the nevoid basal cell carcinoma syndrome, okay? In which one of the most important things you see. Women say yes, you are right. Now it comes. But no, I understand it's not an easy subject. But the reason to know, even if you don't remember the word basal cell, that is a big deal. But to suspect something is more than normal. This is not one OKC, this is many OKC. So the patient must be having some problem. I think that is most important, because obviously me and you, we are not going to make the gene mutation test. Somebody else will, and then the physician will follow. But the very suspicion will make you right, refer to physician for syndromal example, something like that. That's the most important thing. 68-year-old male, and we do it all the time. We make a comment. Because you're not supposed to know everything, but we make a comment, please refer the patient for evaluation of syndromal condition. That's it. You've done your job. This is medical legally correct. You're putting in legal documents. Now if your referee physician is not checking, now the ball is with that person. Okay? You've done your work. Completed. And believe me, medical legal means may not sound big in Saudi Arabia now. It's going to catch up. 5 years, maximum 10 years. You will be hearing of legal suits, lawsuits, all things will happen here also. It will be the same for everywhere in the world. It's going to be the same. There is no difference. In 10 years, everybody will face the same problems. So as dentists, you should be aware that you have to keep good relations with your patient. There was a very long research done, longitudinal study, where they found significantly all the lawsuits that happened for dentists or for doctors was because of misbehavior more. So even if you make a faulty implant, but your relationship with the patient is good, you can explain to the patient, you can rectify the problem, you can give him a new implant or take care of the problem. Relationship is good. Sometimes people misbehave. That's what you don't forget. You should always have that good relationship with your patient. So this was radiolucency on the number 9 feet, which is obviously the left central incisor. Now, looking at the histology here, we have a very similar line, which is thick, but you also see orthokeratic now, okay, not parakeratic. So similar to the odontogenic cyst, but there is no palissading of the basal layer. So this is a specific type called orthokeratinized odontogenic cyst. Okay, it has a very low recurrence potential. So the important, you may say and wonder, what is the need of studying all this entity? In this whole pathology, we understand big D, why this is happening. Each has a different treatment plan. That's why it is important to look at that. Otherwise, you can say, nonsense, just get it out and throw it, it's over. But each has a different potential, and that's why you need the right diagnosis. So clearly, recurrence rate is only 2%. Number 12 case, this is an A and a B. 70-year-old male, mandibular gingiva between teeth 21 and 22. So I suppose when you say 21 and 22, we're talking about the left quadrant on the mandible, which I think for us will be 33 and 34. Okay? I'm sorry, but I also forgot. Okay, it's out of practice now. So clearly, a small radiolucent area right there. Now it starts to show some radioplasticity between the roots right here. Slight divergence. More of the same. Now you start to see this very mixed radiopaque, radiolucent shadow. Starting to get honeycomb-like. And these are all different examples of the same entity. I'm sure you can make a diagnosis now. Now this is what somebody was mentioning before in place of rolling cyst. The other one. The other entity somebody said. This is spring box COT. So COT is nothing but calcifying, which is the calcifying epithelial, and it is an odontogenic entity, so odontogenic tumor. So it's a combination of calcifying epithelial, and that is the calcific zone. What was the name of these calcific areas? Ring, absolutely, ring. That means you have it. This is again ring calcification, wonderful. And what do you think are these products? What is the nature of the product? Amyloid, absolutely. Name one stain, how do we confirm this? Suppose I see this case, it comes today, 38-year-old female with mixed radiolucency, I put it in the section, I look at the slide and I see some spot, but I don't see a classic. I see some here and there deposit. What do I do to confirm that this is amyloid? Histologically, you are fine. It is amorphous. You do a shape for Congo red. When you run Congo red, it will show like any very slightly red pale shadow, but you put it on the right side. Then you see what is called apple green. I don't know. There are green apples in the right? That apple green birefringent. So when you move the polarized light in and out of focus, you can see this shiny green light that confirms the presence of that antibody. We don't have these slides, privilege today, but I got that actually for you in the slide set. Inshallah, next time we can show them birefringent also, which is very interesting because the same procedure is also used for amyloid for other parts of the body. You know, this is amyloid in COP, but with an amyloid, another entity, which one? Capturing thought, hematology. Hematology, so just remember, multiple myeloma is a cancer of plasma cells. We are also having to produce amyloid, same material. So we are being confirmed that through. But this is a COT, you're right, Kinberg's tumor. And the only thing that is confusing to clinicians, and when this slide goes to medical pathologists, they see these cells and they think this is malignant because they see the big nuclei. They have no idea. Medical pathologists have no idea about organ inclusion. And this, even today in America also, they don't understand. But we are lucky because our medical school and dental school are combined. And we have double position. So we are in dental school and we are also associate professor in medicine. They will not sign out anything from head neck without bringing to us. And we do not sign out anything from skin and blood without showing them. So if we get a lymphoma in the mouth, I know it's a lymphoma, but I'll take it to them, show it, get their opinion, then I'll decide. So we work interdisciplinary, okay? Very much. Number 13 is a 44-year-old female radiolucency of the right mandible. So clearly, if you see, there is some asymmetry there. Or the swelling of the jaw. How would you describe this? Yes, multicystic or multilocular and almost starting to look like a honeycomb, which involves the crown of an impacted tooth. So what do you think is another entity, not amyloblastoma, but something other than amyloblastoma, which is also anti-honeycomb-like with pretty aggressive lesion inside the bone? Look at how actually in the posterior jaw. So this is the same patient, this is the hemimandibulectum. You see the condyle, that's the coronoid process, and this is the lesion. So this is an entity called odontogenic myxoma. Remember, myxomas are pretty aggressive lesions. They can actually creep within the bony lacunae and cause a lot of destruction. This was the reconstruction of the patient. Multiple other examples. And that is how you see it under the microscope. In fact, for us it is very important what the clinician describes. So tomorrow, if you become an oral surgeon, okay, you go and you do a surgery and you send the case to Dr. White or to the department and you say, hey Dr. White, you know, I did this surgery, I found the specimen, it was very like jelly. Something like jelly came out. And I tell you it, he will know that one light bulb will glow in his mind. And they do, you know, you saw me and jelly. So even before we look into the slide, in our mind already we are thinking about the soap. Now we only confirm it, you know, by the so for a pathology, then it's quite easy. No, your clinical eye is very important to the pathology. What you see, what you describe, the radiograph, the very. So we have in all our lectures, our CV lectures, we just keep telling as many as possible. Give us more history, more background, what is the patient eating? Many years are from the list. What is the diet in chart? What is the patient doing? Some people are using chewing gum. Some people are using nicotine products. You know, nowadays so many things in the market. Lipsticks. We have treated a case of oral patient granulomatous. 7 clinicians failed. And we get all the bad patients. Nobody wants to be with it. So we are in the university because, you know, private practice people don't want to waste time. They will sell. Most patients will come to us and we have half-day clinic. I went to 7 doctors, 3 dentists, 4 physicians, and look at my label and things like that. So history, found maybe a lipstick problem. Somebody chocolate problem. Young girl, suffering for 5 years, full of eczema like that. Some preservative in the chocolate. Stop in 5 days. Alas, finish. Problem for 5 years, treated in 5 days. The main thing is to find the history. So important, so important. The problem may be very small, but you are not thinking about it. So another important thing or takeaway is, if you diagnose any patient in your life, and you're treating the patient for 2 weeks, but you don't see the result, don't change the treatment, change the diagnosis. Okay? Then you need to change and look at the diagnosis of the patient. That means there must be some mistake in the diagnosis. Because I always tell my students, the rule of thumb is 2 weeks. Anything in the world should go away in 2 weeks. This is how nature created us. Body will heal itself in 2 weeks generally. Anything that goes beyond 2 weeks, lose suspicion. There is something more happening. Okay, that's how you will be able to get some more answers. Class. And you can see the recurrence rate, 25%, which is substantial. I'll leave the lecture with Dr. Weil. There are very interesting things in the epithelium also to learn, carcinoma, dysplasia, very interesting. So, inshallah, I'm sure you can, rearrange it as a resource and it will help you guys. So thank you very much for being a very supportive audience, and I'm very happy to see your knowledge base, and I think they are doing a very good job. I must tell you, they are doing a very good job. Congratulations. Very, very good job. I think they're doing very good. Yeah. They're very good. We may discuss with them.
If you wish, you may discuss it again.
Oh, no. I think I've already discussed. I think they're doing pretty well. I mean, if you want to discuss anything, anytime, I will leave my email with Dr. Weil. We have a program in Florida. We have many programs. What they do, what they do for all. But for oncology also we have a program, and that is a 3-year program. And we also get students 2 per year for internship, which is 1 year before the program. So 1 year internship to finish the requirements, like national board, get used to the setup. Don't get me wrong, but when you grow up here, there's a very different social life. America is very different. It took me about 5 years to even understand jokes. Because when people are laughing, I was laughing. But then I would ask, why are they laughing? So it took me some time. And I was not very unsmart. I was not very intelligent. But I was okay smart, from India, I knew a lot of things. I was very good global knowledge, but I used to laugh, what are they saying, all the time. So that 1 year is to make people comfortable in the program. Then when you start the real program, you will just glide through it. That's the main goal. So, inshallah, if you have any interest, I live for my students. So, email me anytime, you will get a reply. If not today, within 24 hours, within 48 hours, you will always hear back. And we try to do that. We have no layers. There is no layers. You can reach direct. No secretary, no secretary, other secretary, no email, and you will get a direct reply. So, any question anytime. And for you,
I have one.
Yes, please.
I dealt with students from طيبة, from all the students, they are complaining that oral pathology is a tough subject. And we might not be in need for oral pathology in our future. Do we have to study oral pathology?
Let me tell you one thing.
Or why you are forcing us to study oral pathology?
That is, number one, I think it is a lot of mistakes from our side. For me, this was the most painful subject when I was in it. You will be surprised when I was. I used to hate it because my teacher made us hate him. He used to come. the way you should know the world, like not even trying to see where we are. I want to understand. He made it so disinteresting and distracting. Like for me, oral pathology class was like the most fearful and scary and boring. I just hate it.
This is true. Being bored.
Oh, they are pleasing you. Because, also I learned very early in life that you should not stick your neck out. By that person, you actually put your neck into the line. We always are taught when we go for oral exam, don't say something you don't know, because you're putting your
Don't put yourself in any board.
why put his neck in the line? But no, seriously, jokes apart, I think there is a great need. I think whether we like it or not, definitely knowledge more, experience more is in a very different level. And even today, our own pathologists from medical school, they come and tell us, what would we do if we didn't have these guys? See, this is coming from the medical pathologists. They are telling us, what we do if we did not have them. So the answer is right there. We actually do a course for medical school. We go and teach them pathology. You cannot imagine how happy they feel when we tell them dysplasia, when we tell them the age. Because there is these surveys, for vagina, they have cancer. But cervix dysplasia is one different category. So when we explain to them, they are so appreciative. They say, thank you for telling us. When we show them the board instance, very happy they are, because nobody teaches them that. So, it's just your answer to the question. I don't think we should move away. I think we should move more into it. Because it's a growing market, it is untapped, completely untapped zero. Even in America, it's untapped. We are the second biggest market, 11,000 one year, 15,000 in New York, and 8,000 in Texas. Overall, total production in America for oral pathology, $40 million. This is nothing. $40 million, only my pathology in medical school, in our school, alone, the pathology they are making. And this entire America does $40 million. The market is open. Similarly, I don't think anybody is even doing professional market service yet. Whoever will open it will do it. Last year, our production, I told you, about $2 million. Between 3 people. We are only 3 people. So we teach, we have patients, we do residency programs, and we have this very, very aggressive market service.
So for me, then I'd like to ask you, how can I start with oral pathology?
Make payments. That was my goal. What I did was, I was not smart. I was not a smart student. I was not an intelligent student. But I knew what has to be done. So my goal was to make formula and clues of what should be done minimum. My concept in life is minimum investment, maximum return. That should be all of our goals. Because like you, I like Facebook, I like watching TV, I like shows, I like everything like every other person. And I have my family, I have to give them time. So I cannot make my job my life. And I cannot change my life for my job. I'll give you a small example. Say, you now know odontology, okay? I'll give you a generalization. Any question in odontology, if somebody says the lesion is in male or female, every odontology dentist you read is more common in male. Okay? But I don't remember that. What I try to remember is which one is not in male but more in female. So you have to remember only one thing. If you remember all the ones in male, you have to remember 20 male. I just remember AOT, my job is done. So I'm just giving you a small example. When you do salivary gland, same thing. Everything is in female, only one thing is in male. I remember walking tumor, finished. When I go to sleep, because I'm done. So this is my approach to life in everything. Remember one twist which is important and put the others in the general category. So it is, it is an algorithm. This subject is algorithm. You are always opening folders in your laptop. What is oral pathology? Oral pathology is one folder. You click on it, opens to benign malignant, epithelial mesenchyma. It is folder into folder into folder. This is how we arrange it. Now,
So this is the same example. It's
absolutely.
like a folder in the computer. You open the link, you will have the
Now you can say, okay, this is very easy to say, but the folders are very big and becoming bigger. I agree, but at some point of time, this is the time when you are getting them out. How many years will you be in this school? Okay, tell me. How many years? 4 years? 6 years? But first year is pre-Daniel. Then you have some other thing, but actual core curriculum is 4 years. Right? So, 5 years. So, the 16 shahad, right? 3 months. And you are going to live for how many years? 70 years. So, your 70 years of bread and butter are going to come from 60 months of education. Of course, you have to bring in as much as possible. It cannot be what he is teaching or what he is teaching or what I'm teaching or it is. It has also to be what we can take in. You know how we teach our residents? If this is a paper, for example, and this is a history sheet, the patient's name, clinician's name, and here symptoms, color, duration, radiograph, some drawings, okay? The residents have to look at this. If the patient's name matches the name of a syndrome, the next day when they will question them, they have to know about this name also. Because we will move away from the main topic and ask him about this syndrome. So this is called global knowledge. You may not have deep knowledge about everything, but you should have little knowledge about something. So the name it says Luna, Maria Luna. Let's say, okay, tell me about Luna. You should not do that because you are clinician. Not always Google will help you in life. You know, when you're sitting next to a patient, Google is not, Wikipedia and Google are not going to be there all the time. There will be some idea. Okay, this is the development of this stuff. What can happen? Oh, there may be some dermatology feature. But some basic concept has to be there. This is how we teach. So they have to be ready. So what we do is, we leave the biopsies today, all the slides are there, we go to the residents, the PG, master students, and they will look at it, all of them. Then we meet next morning in the multi-scope. We have 10 head scope. You know, 10 people can look at the same slide. Then we will pilot the slide and they will now bring their answer. So each will be asked with a question. Then we will tell our diagnosis. And then the computer, which shows what I signed out the previous day. So if I got something in glioblastoma, they can see it next day but after the session. So we will match with the diagnosis. And if I have difference in opinion, they can question me. Because that's what I it doesn't work like I'm teacher, so whatever I'm saying is solution. They will say, no, but you can see this, why did you call this? Then I'll say because of this. So it is an interactive session. After that 2-hour session, finished. We don't see them the whole day. They read themselves. It is a self-driven program. We call it self-driven because the more in those 3 years we can get in, we become better. So the concept is, you bring some ideas on the table, and there when we learn, even we learn with them, you know. It's not always teaching, we are also learning every day. Sometimes they will bring a good concept, oh wow, that's amazing. This is a great idea, you can know it. Then just the other day, one of our residents said, you see that lymphatic vessel, from these arms, those are developed. I didn't know that actually those are not, I never knew, I never read that. I said, well, he said, I went to rotation, medical pathology. They told her, you don't know the law of the lymphatic. It's a good way to know how lymphatic channels different than others. So we all learn every day of the life. Nobody can say we know everything. Nobody can do it. So it is a dynamic process. Inshallah you will do well, but try to get in as much. Always think 60 months and then you're out. What you bring in your head in 60 months, that is going to be with you for the rest of your life. So a little burning now, then the gold will be shining next, you know. You know how gold it will burn it, then it will shine. Or the diamond, you know, the more the cuts, the more the shine. So this is the time. Give yourself a little more trouble, go a little extra mile, inshallah, you will rise. I can tell you. Yeah. We all go through difficult times, but this will go away and more times will come. So you have to decide what future you want. So thank you so much.